Urinary incontinence is twice more common in women than in men. About 1 out of 3 women over the age of 60 is estimated to be incontinent. Pregnancy, childbirth, hormonal changes during menopause, and anatomy of the urinary tract account for this difference. Urine is produced in the kidneys and stored in the urinary bladder. Urination is the process of emptying the bladder through the urethra that connects the urinary bladder to the external urethral orifice. There are 2 sphincters or valves that keep the urethra closed to prevent leaks: internal urethral sphincter located at the neck of the bladder and external urethral sphincter located right above the external urethral orifice and supported by the pelvic floor muscles. The urethra is much shorter in women than in men. When the bladder is full, stretch receptors in the wall of the bladder send a signal to the spinal cord and the brain. At times, when it's not appropriate to urinate, the brain sends back an inhibitory signal to keep the sphincters closed and prevent voiding. When you wish to urinate, this inhibition is removed. The spinal cord instructs the muscle of the bladder to contract and the sphincters to open to let the urine out. Urinary incontinence is involuntary leakage of urine. There are several types of urinary incontinence in women. Stress incontinence: urine leakage while sneezing, coughing, laughing, or any activity that creates abdominal pressure on the bladder. This usually occurs because the muscles or tissues underneath the bladder are weakened and can no longer support it. In women, this typically happens as a result of pregnancy and childbirth, during which these muscles are overstretched. Stress incontinence symptoms usually worsen during certain times of the menstrual cycle when estrogen level is low. Incidents also increase following menopause. This is by far the most common type of incontinence in women. Urge incontinence: need to void that cannot be deferred, inability to hold. This is commonly caused by an overactive bladder, a condition in which muscles in the wall of the bladder contract in an uncontrollable manner. The reason why this happens is unclear, but it's likely to involve problems in the nervous system. Overflow incontinence: constant dribbling of urine. This happens when the bladder does not empty properly while voiding, making it almost always full and urine overflows. This may be due to weakened muscles in the bladder wall or a blocked or narrowed urethra. This type of incontinence is rare in women. Treatment depends on the type of incontinence and severity of symptoms. Lifestyle changes: limit fluid intake at certain times of the day, such as before going to bed or before a long trip. However, note should be taken to increase fiber content in your meals to prevent constipation. Cut down on caffeine, alcohol. Keep a healthy weight. Try pelvic floor muscle exercises, such as Kegel exercises. This is to strengthen the muscles that support your bladder and is particularly recommended after childbirth. Timed voiding or bladder training therapy. Plan regular trips to the bathroom at set times of the day. Gradually increase the interval between trips as you gain control. Small leakage can be managed by wearing menstrual pads. Medication: depending on the cause of incontinence, the following types of drugs may be prescribed. Anticholinergics: these act on nerves to block bladder spasms for treatment of overactive bladder. For stress incontinence, topical estrogen may be applied as a cream or patch. Estrogen helps to tone muscles and tissue around the urethra to keep it closed. Non-surgical therapies for stress incontinence include pessary. A ring-shaped medical device can be inserted into the vagina to hold up the bladder neck. The ring needs to be taken out and cleaned regularly. Bulking agent injections. Bulking materials such as collagen and carbon-coated beads can be injected into the area surrounding the urethra to support and keep it closed. This is a minimally invasive procedure but usually has to be repeated to be effective in the long term. Surgical procedures include sacral nerve stimulation, treatment for overactive bladder that does not respond to medication. A small pulse generator device is implanted under the skin of the buttock. The device sends mild electrical impulses to the sacral nerve, the nerve that controls bladder activity, to moderate and control bladder spasms. Bladder suspension or sling procedures may be performed to create an artificial support for the bladder neck or urethral sphincters. These procedures usually involve tightening of the bladder neck or the urethra to strong ligaments within the pelvis or to the pubic bones.